Lymphoma is a very heterogeneous cancer of the immune system. And the immune system is made up of the cells called lymphocytes, and the immune system consists of lymphatics and little nodules called lymph nodes. The immune system actually follows the blood vessels, so the immune system and the lymphocytes and lymph nodes are throughout the entire body. Lymphomas are often associated with other immune disorders because this is an immune disorder and you may have a increased risk of infection with lymphomas. The most common non-Hodgkin lymphoma is referred to as diffuse large B-cell. It accounts for about 35% of all of the non-Hodgkin lymphomas, so it is the most common. It is one that is curable in a large percentage of patients, and the standard of care has been a combination of immunotherapy and chemotherapy, and the standard of care today is a combination called rituximab and CHOP chemotherapy. All lymphomas tend to be increasing in incidence, and the diffuse large B-cell is one of those. The reasons we think non-Hodgkin lymphomas are increasing is because people are living longer. This is a disease of older people, although we certainly can see it in the young adults also. But also I think we're treating diseases that we never treated before. Patients are living longer. Diffuse large B-cell lymphoma is diagnosed like most of the other lymphomas. You definitely need to have a good piece of tissue to have the pathologist review what's under the microscope, but it's much more than that today. We need enough tissue so that we can do special studies on it. And the special studies that are so important are things where we can actually take the individual cell, have it analyzed, and we can look at the markers on the surface of the cell. That test is called flow cytometry. And then when we have the pathologist review the slide under the microscope, he is now able to do special stains on that tissue. That's called immunohistochemical staining. And we know that for diffuse large B-cell lymphoma, majority of them are what we call CD20 positive on the surface of their cell. They have an antigen, and that's why we can use the drug called rituximab, which is an antibody against that marker on the surface of the cell. The additional way that you make the diagnosis of diffuse large B-cell once you have the pathologist report is that there are certain histochemical stains that pathologists are doing today that can subdivide the diffuse large cell lymphoma into subtypes. And what we've learned from gene analysis of these tumors is that there are actually 2 to 3 different types of diffuse large B-cell, even though it looks the same under the microscope. Diffuse large B-cell often occurs in the advanced stage. I think that there certainly are a few patients who have more localized disease. And if you remember, when we stage patients with lymphoma, we talk about stages 1 through 4. And again, stage 1 is if they have lymph nodes in one area of the body only, for example, the neck. Stage 2 would mean if they had disease in 2 areas of the lymph nodes, but on the same side of the diaphragm. Stage 3 is if they have lymph node involvement on both sides of the diaphragm. And stage 4 is if they have disease in sites outside of the lymph nodes, for example, bone marrow, lung, liver, etc. So when I talk about more advanced stage, I'm talking about either bulky stage 2, stage 3, and stage 4. And bulk is defined in different ways, but most of us feel that anything greater than 7 to 10 centimeters is bulky disease. Localized disease, for example, stage 1 and non-bulky stage 2 has been treated with abbreviated chemotherapy with the R-CHOP regimen, and then adding radiation therapy to that. So combined modality treatment. And you don't have to give as much chemotherapy as you do for advanced stage. Advanced stage disease, 3 and 4, are often treated with 6 to 8 cycles of R chemotherapy, that being R-CHOP. There are clinical trials out there seeing if we can get something better than R-CHOP. R-CHOP cures about 55 to 60% of all patients. We're still left with patients who don't respond to R-CHOP. They may be refractory to that, or they may relapse. And that's the group that we really need better therapies for. We know from previous studies that there is really no reason to use Rituxan maintenance in diffuse large cell. But there are other agents that look promising, and there is one drug which is called an mTOR inhibitor. It goes by the letters RAD-001. It is being added at the end of treatment to patients with R-CHOP as a maintenance type for 1 year to see if it may improve outcomes. There are drugs in the relapse setting that are also very new that are looking very effective in relapse lymphoma, a drug called lenalidomide. That also has been very effective against the activated B-cell type of diffuse large B-cell. Many novel agents are available for both frontline and relapsed diffuse large B-cell. The role of clinical trials is underutilized in this country. Patients with diffuse large B-cell can be offered many clinical trials. There are several clinical trials open for patients with diffuse large B-cell, especially when it's in the more advanced stages. There are 2 different types of diffuse large B-cell. One is more aggressive than the other. And even at our own institution, we have a trial right now looking at patients with the activated B-cell type of diffuse large B-cell, where we add to the R-CHOP regimen a drug called bortezomib. And so you want to do as much as you can for the more aggressive types of the diffuse large B-cell. So there are many clinical trials out there. Sometimes patients don't know about clinical trials. They are not aware that they can get information on clinical trials, even though their doctors perhaps have not discussed that. And I think there are many resources for patients looking for clinical trials. The biggest website where all clinical trials are registered is www.clinicaltrials.gov. The lymphoma.org website has many clinical trials listed, and they actually will separate them into the type of lymphoma that you have. So again, use these resources and find out about clinical trials. The advice I would give to a newly diagnosed patient with diffuse large B-cell is to not panic. It is a curable disease in the majority of the patients. The second point, I would say, get as much information as you can. There are so many agencies out there that can help you. I think the Lymphoma Research Foundation, with their website, has offered so many podcasts and webcasts and information on the most common lymphomas. And this is the most common lymphoma. It is curable in most patients with a regimen called R-CHOP. And patients need to hear that. They need to get as much information as possible. And they also need to know that, if they happen to relapse from the disease, that if they're in good health, we can still offer a curative treatment to them with the potential of an autologous stem cell transplant. I recommend that patients get as much information as they can when they have a disease.